Hello everyone, and welcome to another session of EVMS UltraSoundbytes. My name is Suzanne Dickinson. I'm one of the instructors for the ultrasound program here at EVMS. Today we're going to be doing another MSK session, and hopefully you have already looked at the MSK General and can follow along with this one well. And we're going to be covering the knee today. For our ultrasound session objectives, they're going to be similar throughout all of these sessions. We are going to give an introduction to the clinical application or the point of care that you will be using this kind of ultrasound for. And we're going to be looking at the sonographic signatures of the MSK tissues as they relate to the knee. And we're going to also look at machine setups and options that you can have to optimize your image, as well positions that you can put the patient in to optimize your acoustic windows. We'll also go over the acquisition of images and some pitfalls and pearls that you may run into in trying to scan MSK. And finally, we'll be looking at SPI snapshot and, of course, the scanning cards that will be on Blackboard that are going to assist you in your journey to get through the badging program. So the purposes of an MSK knee sonogram and be several, even for point of care. We're going to be evaluating for tendon tears, and we would want to look for bursitis or effusions or cysts, namely Baker's cyst. There can also be other kinds like ganglion cyst, but the Baker's cyst would be the most common. And also we want to be able to focus on the nerves that are visible to us so that you can apply those concepts to nerve blocks. And in this case, we're going to be looking at one of the more obvious nerves. So for this, as always in MSK, you'll have to consider the relational anatomy and the sonographic signature of certain structures. And those would include the bone, plus the topography of the bone. So as you think about the bone and all of the lumps and bumps, as we kind of refer to them on the bone itself, you can see those visibly through the skin, and knowing where those are is important for you to find the structure that you want to find. So also you need to think about where the nerves are tracking through the knee, and in this case we'll just focus on the tibial nerve, and we may or may not be able to see the common fibular nerve as well as the sciatic nerve. With tendons, you're going to want to be able to identify the patellar tendon, which is obviously going to be going for the patella to the tibialtuberosity, and the medial and lateral collateral ligaments, which can be very challenging depending on the age of the patient or the condition of the knee. And of course the quadriceps tendon, the front of the knee, superior to the patella. And also the accompanying muscles. And I pick out a few of them here. Of course, the quads are going to be related to that quadriceps tendon, but the semimembranosus, semitendinosus, and your gastrocnemius muscle, particularly the medial head, are important landmarks to know when you want to find a Baker's cyst. And also, you need to know where that Baker's cyst is coming out of, because this can also interfere with finding the tibial nerve if you are looking to do a nerve block. And finally, bursos. Most of the bursas that we can see, well, there will be infrapatellar bursa and suprapatellar bursa that will always have a little bit of fluid in them so we can identify them. Typically the bursa won't have fluid that makes them very visible on a normal knee, but you still need to know where they are. So let's take a look at bone topography here. When we look at the leg, and one of the first things you'll notice, even if you're looking at your own leg, is you'll have some bony protuberances on either side of your patella. And if you put your hand across there, you're going to feel them, and those are the femoral condyles, your medial and lateral femoral condyles. And if you relax your leg, and you can feel your patella bone, the patella, sitting above those condyles, and it's really quite mobile, and you know that that is a sesamoid bone, and I like to think of it as the queen of the sesamoid bones. It's the largest one visible. And then the fibular head, if you go to the lateral aspects, you can feel the fibular head on the lateral portion of the leg below the kneecap, and actually quite lower than you think. So let me go back to the femoral condyle. So if I take my thumb and my index finger, I place it on either side of the patella, I can feel the femoral condyles here. Then of course the patella, we all know what this is, right? Go ahead and let your knee relax. There we go. So it sits right on top, and it's going to sit in a groove between these condyles known as the trochlea. And we can actually see the trochlea and do some basic analysis of it when we're looking at it. And now the fibular head, what I do is I take my thumb and I'll run it down the side until I can feel the bony protuberance of the fibula down here, and that's going to be an important landmark to find, because I'm going to be looking for the lateral collateral attached to there, and also be aware that the biceps femoris attaches there and can actually confound looking for the lateral collateral ligament there, and I'll show you that later. Now the tibia are going to have a couple of landmarks. If I come down below the kneecap, you're going to see that first little bump there. Below the kneecap with this first little bump here, you're going to find the tibialtuberosity. Now, if I then just move lateral to it, there is another little bump here, and we commonly call this the Gerdy's tubercle, but it's technically the anterolateral tubercle. This tubercle is very important to find because that's where your iliotibial band is going to attach to, and oftentimes there is a bursa in this area, and oftentimes this is the area that gets irritated with runners. And so knowing the bony topography is going to help guide you in where you're going to find the structures that you're looking for. So connect in your mind those bony structures, and how would the structure you're looking for travel to its other attachment, and that's going to guide you on how to put your probe when you begin scanning. Okay, sonographic signatures. Now, anisotropy is a really significant problem with the knee, and particularly when you get to some of the smaller tendons. The larger tendons, though, as in this image of the distal patellar tendon, we can see it attaching to the tibialtuberosity, and it does have that classic appearance, that fibular appearance, and then that bird's beak, as we refer to it, attachment to the tibialtuberosity. Deep to the patellar tendon is going to be an anechoic area, and that's actually the infrapatellar deep bursa. There is also a superficial bursa, but we typically don't see it unless there's a problem, and it'll be above the tendon. So for the larger tendons, our sonographic signatures sort of follow what we have been telling you all along, that fibular pattern that you see of all of those bundles of collagen. However, lateral collateral ligaments or medial collateral ligaments, those can be difficult to get directly perpendicular to them, and on some people, and particularly an older knee, which this knee is, they can get a hypoechoic appearance to them. The arrowheads are showing you that medial collateral being attached to the medial condyle of the femur, and so this is the proximal attachment of this. So my point about anisotropy is you're not always going to be able to avoid it when you're looking at these structures on the knee. All of the tissue signatures are going to be very similar to what we've been teaching you, from subcutaneous tissue to fat pads and to the cortex of the bone. Those will all be very typical. So just remember your probe movements too, to sort of compensate for these problems, your heel toe, your sweep, your pivot, so that as you're imaging the anatomy, you make tiny little movements that can get you more perpendicular to what you're looking for. Now, other challenges for a clear image of the anatomy, and I'm going to show you all these things on our patient today, but this is a dissection of a knee, and so what I wanted to point out here more than anything is the LCL, which is the lateral collateral ligament, coming down to attach to the femoral head. Now the biceps femoris you see is also attaching. So there's going to be a point at which the biceps femoris is going to interfere with your view on the lateral collateral ligament. So if I put a probe across here and then I look at the image, again, this is an older knee, so we do have a hypoechoic echo texture to the lateral collateral, but when I put some labels on here, and I'm going to go back again to take the labels away, you can see how the biceps femoris can confound your ability to see the ligament easier. They're both headed to that fibular head. And so those are the things that might confound when you're trying to establish what you're looking for. Let's go to the machine and take a look at some of these structures we've been talking about. Okay, so as with everything else, when we do an ultrasound, we want to walk up to our machine and be sure that we have the appropriate probe attached, and in this case it's going to be our linear probe. And we can see from the image that this is indeed the linear probe. And of course we'll want to go to our patient data, and our patient data will show us in the last name we want the structure of interest. And in this one, since we're going to be doing several images of the knee, let's just go ahead and put knee in the last name, and your first name is just going to be the class that you're in, and I'll just put MED in, just as a placeholder. And once you have that in, you press your OK button, and that will take you right back to your screen. So let's talk about, thank you. So let's talk about our anterior knee as our beginning area. Now we're going to start at the top of the knee because we want to start with structures that we're going to be able to see very clearly. And you can actually grab a hold of the quadriceps tendon, and you know that this is going to be the spot at which you're going to be scanning. I'm going to place a little bit of gel along that line because that's where I'm expecting to see my tendon. And let's remember too that the notch on the probe, just as we've talked about in previous MSK, is always going to point proximally. And so I'm going to point that probe proximally because I'm going to take a long axis view, and I'm going to place the probe directly on her knee. And as I move down, I'm going to take a little bit of depth out of this. And before I go on, I do want to point out one last thing that I didn't point out to you. This is in the MSK Exam. So if I come over to the exam button and I press that button, you can see I have a whole list. Now I'm picking MSK, and that'll give me a more shallow beginning, and it will set the dynamic range in a reasonable setting for me to be doing MSK. So let me go ahead and hit my set button, and it does come in very bright, and so you oftentimes have to compensate for that almost immediately because you don't want your anterior imaging to be this bright. So I'm going to come over to my gains, and I'm just going to move them down overall. I also want to point out to you, take this off of here, I also want to point out to you that your dynamic range is going to be set at 127. Now you really don't want to go any higher than this, and this is a pretty good setting for you to be seeing the fibular pattern of the tendon. However, if you ever want to change this, change it lower, not higher. And to do that, there's two ways that you can do this. You can see that when I hover over this, that it highlights it. And if I use my radio dial, ooh, it's not going to work on this particular machine, I take it back. So I'm going to take this back down to my menu, and I'm going to click downward on the menu. And you'll notice off to the right of the screen, you see dynamic range, and it's set at 127. This is not a number you really want to go higher than, but sometimes you want to scan a little bit lower, and this is where you would change it. And all that does is just increase the contrast between the higher amplitude echoes and the lower amplitude echoes. It makes the fibular pattern a little bit more discrete. All right, go ahead and take this back over here. I'm going to bring us back to focal position. All right, so here is our quadriceps tendon. Here is the cortex of the bone of the patella, and you can see that bird's beak attachment as it comes up over the patella. I also want to point out, and I'm going to bring my focal zone down, that in this patient you'll see a little bit of fluid right here, and this fluid is supposed to be there. It's a bursa, and it's separating. This is the suprapatellar bursa, separating the suprapatellar fat pad from the prefemoral fat pad. This is the cortex of the femur. So know your relational anatomy. You should have a more superficial tendon, then you'll get those cushioning fat pads, then you get that cortex of the bone, as well as knowing where your kneecap is, seeing the cortex of the kneecap. We can turn transverse on this tendon. And I'm going to put my cursor on it, and I'm going to follow this tendon all the way up. Our patient is clenching her muscles there. You can see them clench. Here's our tendon here. So what we're seeing, do that again. We see that one really tighten up, that's deep. Go ahead and relax. That's intermedius. So that's the one muscle that we don't see when we're looking at topography. If I was looking at the patient's thigh, I would be able to see, particularly those that have well-defined musculature, you can see the lateral vastus lateralis, the vastus medialis, and here's the biceps femoris tendon. I'm going to keep going upward till it becomes a muscle, and here's the muscle. Okay? Remember that ultrasound is very dynamic when it comes to MSK. Now I'm going to go ahead and take us below the kneecap. So below the kneecap, below our patellar, we're going to be looking at the patellar tendon. Now I'm going to add just a little bit of gel. You want to be very generous with your gel when you're doing MSK. So I'm going to, again, my probe is going to be facing proximal when I'm doing MSK Long Axis, and I'm going to put that probe right at the kneecap, and right away, very superficially, we're going to see the tendon fibers, that classic fibular pattern of the tendon fibers. I'm going to move proximally to bring in the kneecap or patella, and you can see the patellar tendon's attachment to it, and we see subcutaneous fat here, that protective fat, and then we see that heterogeneous fat that sits below the tendon, which is Hoffa's fat pad. This fat pad is protecting that area in there between the joints. As I move distally, I need to make one other adjustment here with my focal zone so we can see this better. I'm going to go ahead and take some depth out so we can see that fibular pattern. And also because I want to demonstrate to you that the minute you start going very shallow on the mind ray, you can pixelate the image a little bit and take away some of your perspective. So be sure before you take out depth that you know what you're wanting to follow. So I'm going to follow this patellar tendon all the way down towards the tibial tuberosity. And I'm going to have to put a little more gel on it. This is what I mean about the gel. And now we see the tibial tuberosity come into view right here. And we can see the attachment of the patellar tendon to that tibial tuberosity. Now, where the bursa would be in this case is you're going to see one in this area, if you can see it. There's a faint amount of fluid in her deep infrapatellar bursa, but the superficial infrapatellar bursa is barely perceptible, and that's the way that it should be. Now, if you need a little bit of perspective, go ahead and change your depth again, just to give us a little bit of perspective of this whole knee joint. And you can see the effects of anisotropy here. I'm going to put a little bit of pressure, heel toe, and really straighten out these fibers so that I can compensate for that anisotropy. Now I can turn transverse, and I want you to appreciate just how wide this patellar tendon is, all the way out. And we could run up and down, proximal to inferior, and see the width of that tendon. I'm going to turn long on it one more time. So that's the patellar tendon. Now, if we want now to go to the lateral aspect, we would want to palpate our fibular head. So I'm going to go ahead and palpate the fibular head, and I'm going to place my probe, the heel of my probe, on that fibular head. I'm going to come down so you can see it. There's the fibular head right here. And her collateral lateral ligament is here to here. And I'm going to follow this on up. We're going over the joint space here. This is the meniscus sitting in here, this triangular. I'm going to keep moving towards the lateral condyle of the femur, because now we're in the area of the femur. And you're going to notice this little depression in here and another fibular pattern, and this is the popliteus. Again, knowing your anatomy is going to help you identify what you're seeing. Riding over top of that, we can see the lateral collateral making its attachment to that lateral condyle of the femur. Now let's see if we can go ahead on down towards the distal again, and on her, here is the biceps femoris here, and I actually have to make a few little adjustments to get off of it and be able to get back into the tendon. And then here's the tendon riding up over the top. Here's again her biceps femoris here. So just be aware of the anatomy that's going to be in the area. Now, if I make just a movement with the heel of my probe towards Gertie's tubercle, I'm going to palpate Gertie's tubercle. I'm going to move the heel of my probe over to Gertie's tubercle. And when I do that, I easily bring in, and let's take out some depth so you can appreciate it, I easily bring in the iliotibial band right here. And we can follow that iliotibial band to this problematic area up in here where they tend to have pain. Okay? Now that's the lateral side. Now let's move over to the medial side. I'm going to take a little gel with me. Add some gel to the medial side. And what I use for my landmark here is I come just about the level of the inferior patella, and I feel for a depression that is the joint space. And I'll put my probe over that depression so that I can see the joint space, because then, right here, so then I know I'm in the right area. And then I begin to make my little sweeping movements or heel toeing movements so that I can really identify this joint space, because I know that riding above it is going to be the medial collateral ligament. Now if I move superiorly, you will notice how thick it is superiorly, and it has a superficial brighter area and a more hypoechoic deep area. And this deep area will attach itself to the medial meniscus, and in fact this is why we have our unhappy triad when there's injury to the medial meniscus and injury to the medial collateral ligament. Now we can follow it on up to its attachment. Let me get up here. On the medial collateral, the medial epicondyle, and this is where most tears will occur, is up in this more proximal aspect of the medial ligament. Now as we move inferiorly, we start getting past the joint space, we see how much thinner it is, or I guess less thick that it is. And it's actually a bit more challenging to follow it. I'm going to keep my cursor on it. And it's going to be kind of hypoechoic to the surrounding or the overlying fascia. And I'm going to keep following it down. And it will actually can attach as much as 6 inches below the tibial plateau. And it's still going. And it's probably attaching right in here. So that would be your medial collateral, and you'll want to practice heel toeing and sweeping to bring it into view as much as possible. Now, finally, on your full evaluation of the knee, we have the popfossa to go through, and that'll be the last thing that I'll show you. Let's see here, I'm going to wipe off some of her knee here so that she can roll over. I'm going to remove the cushion. Go ahead and roll back. Oops, sorry about that. Okay, so our patient is going to be in a prone position, and we'll notice that we can look at the popfossa, that triangular area in the back, or we would call it a triangular area because of the way that the muscles, if you try to remember and imagine if this skin layer wasn't here, which of course we don't want her to lose her skin layer, we would see the lateral head of the gastrocnemius, the medial head of the gastrocnemius, and then quadriceps tendons that will be on either side. As they come down on the medial side, you're going to have your semitendinosus, semimembranosus, and on the lateral side, you're going to have your biceps femoris. And that makes this triangular area that hides our popliteal structures, the artery vein, and the tibial nerve. So I'm going to put a nice generous gel in there, and remember that we're going to be looking a little bit deeper, so right off the bat I'm going to give myself a little bit of depth. I'm going to come in a transverse plane, and again bring my focal zone down and give myself additional depth, and there we get a little bit of perspective. Now, you'll find that you will have to move more superior than you expect. I usually start right in the crease, knowing that I'm going to have to move more proximal, and when I do, I immediately begin to see more hypoechoic structures stacked upon themselves. These are the popliteal vessels, and typically the vein will be on top of the artery, and if I put color flow on here, you're going to be able to see the flow through those vessels. And if you're still wondering, you can see that pulsatility of the artery and not so pulsatile on that vein. I can augment that so you can see a little bit better. If I do a little bit of augmentation, you saw that that filled right in. So the augmentation, go ahead and relax. The augmentation that I performed there was just putting a little bit of pressure on her calf, just a little tap, and that augmented it. The other way I can tell which one is which, of course, is to do our pulse Doppler and look at the waveforms, and you can see again that waveform of the artery and then the waveform of a vein that's more flat. So now that we've established which one is the vein, which follows what we look at when we're looking at these structures from an anatomical point of view, when we're doing our dissections. Let's go back into it. There we go. So here are two vessels. The important thing to establish is that this vein collapses with pressure. So I'm going to add pressure, and you're going to watch this vein, the walls kind of kiss each other. So I'm going to press down and look at them kiss each other. I separate. That tells me right off the bat that I do not have clot in this vessel. So you can carry that concept into any large vein that you'll be looking for when you learn about looking at the femoral vein. You use that same pressure to be sure you don't see clot obscure or preventing that vein from functioning. Now I'm going to do a little bit of a sweep, and you'll notice that this area right in here got a little bit brighter. Is if I lean back, I'm not really perpendicular to the structure. If I then adjust with a tiny sweep of my probe, you can see this bright structure right here, and that is going to be your nerve. So knowing your anatomy, you know that this is going to be your tibial nerve, and it has already divided at this point. The common fibular is actually sitting right here. So if I move superior, let's see if I can do it on this patient. You can see the nerve is right here, and I'm going to keep going. Now it's here and right in here, and at this point you can see how large it's gotten right in here. This is actually sciatic nerve. As we come down, and I'm not going to be able to show you on this patient effectively the common fibular coming off of it, but on here we go. Here's the common fibular, and as we come a little bit down more in distal, here is the tibial. And so if you were going to put any sort of anesthesia, here is, and you were directing it towards the tibial nerve, it would be here. Typically though, you would go more superior to when it becomes the sciatic, or when it is the sciatic, which you know is made up of the tibial and fibular nerve. This is the more obvious place that you would put anesthesia. So what about finding whether or not a bursa is interfering? You would need to come medial, and what I like to do is to find the medial head of the gastrocnemius, and then I like to start moving more proximal until I begin to see, there we go, let me go back in here. Again, this is the gastrocnemius. This is the tendon of the semitendinosus right here superficially, and we have the tendon of the semimembranosus more deep, because as you know, the semitendinosus rides over the semimembranosus, and this is where we're going to find a Baker's cyst, is in this region right in here. Obviously there is not one on this patient. All right, and that's the back of the knee. All right, go ahead and wipe this off of here. We're going to return to our slides. Okay, go ahead and roll back over. You're all done. Thank you. All right, so just to reiterate on the labeling, remember that for this scanning session, under the patient's name on the last name, if there's any different instruction in Blackboard, be sure to look for that, but generally just put under PT would be your patellar tendon, popfossa, because we may be asking you to take a look at those vessels and practice your skills on identifying the vessels. And on your first name, please put your class name. In the black portion of the image, that's where your name and ID go, because remember, we have no anonymous images. We want you to have your name on there, and those are medical legal reasons why you want to be in that habit. It's a good idea also to be in the habit of labeling the anatomy of interest. In this case, this is a left knee long patellar tendon. And also you want to be labeling your anatomy of interest per Blackboard, but just remember that when you do so, that it should not obscure any relevant anatomy. All right, a few pitfalls and pearls. Don't start scanning, and I keep reiterating this, don't start scanning until you've entered your patient information and you've selected your presets. Be sure you have the proper probe attached to your machine before you even begin. And always be aware of anisotropy. I'm going to keep harping upon this with MSK because it really is the one thing that interferes the most with MSK. And just recognize that it can't always be completely avoidable, so know your anatomy. And do set your gains, and if you want, you can even play around with your dynamic range a little bit to optimize those tendons to show their bright fibular pattern. Just be cautious not to go above the preset, because otherwise you get too many gray tones in there, and it just puts this fuzziness over all of the tendon, and you can't really see any sort of pathology you're looking for. And don't set the depth too shallow on the mind ray, because the images may pixelate. So, or if you are going to use a less depth, be sure to use a gel standoff. And you can experiment with using more than one focal zone. I didn't talk about this too much. Be sure, as always, that your focal zone is going to be at the area of concern, at that posterior aspect of the area of concern. But you can experiment with doing two, but just remember that if you're going to use focal zones, that's going to affect your temporal resolution. But if it's not an issue, if you're just focusing on one spot, temporal resolution is not an issue, go ahead and experiment with focal zones. Which brings me to our snapshot. What is focal zone effect on temporal resolution? So it's back to that rule of 77,000 again. And remember that that 77,000 is apportioned to the lines per frame, the frame rate, the depth, and the number of focal zones that you're using. Let's also remember that how we perceive this whole thing going on within the machine is in the quality of our images and how we perceive the frame rate. But what is this frame rate we keep talking about? You should probably know by now we're talking about the refresh. Now, TV shoots at 30 frames per second, and these are actually regulations. They're mandated to shoot at 30 frames per second, and film shoots at 24 per second. And so we're kind of adjusted in our minds that that's what real time is, right? And we can actually perceive it at higher frame rates than that, but this is what we shoot at on TV and on film. With ultrasound machines, it can vary. But the truth is, real time is really any frame rate that we're at. If we're moving, it's in real time. But what are we really trying to achieve? We're trying to achieve a minimum frame rate at which the movement is perceived as being continuous, as well as our quality of our image. So when we try to improve the quality of our image by using a focal zone, which, as you know, will improve our lateral resolution, we do it at a cost. And so we're trading off frame rate when we do that. And so sometimes when we do frame rate, it can get pretty if we use multiple focal zones, our frame rate can get pretty choppy, and we no longer have that continuous feed and refresh. Now, I'm just going to go to the machine and just show you really quickly what that will look like. And let's go ahead. I'm just going to use my own wrist on this. Actually, let me have your wrist. Now, if I'm just going to run up and down this patient's arm a little bit, just so you can see how it seems like there is continuous movement. Notice that we only have one focal zone. Now, I'm going to move this up just a little bit higher so we can see where it is. Turn up our gains. There. And now you have this perception as I move up and down her arm of movement. Well, what happens if I increase these focal zones? So, if we look over here, our frame rate is 47. We're going to increase the number of focal zones. And notice again, that was just 2. It changed the frame rate to 24. Now 24 isn't bad. That's what film shoots at, right? So we might not perceive too much of a difference in that movement. But what if we went crazy on us, right? So let's go ahead and go to 4. And notice how low the frame rate got at 12. Now, if I try to move my probe at that same speed, look how slow the image seems to move. So even though we improve the quality of our image because we're improving lateral resolution, we give up frame rate. And so that's why if you're going to increase frame rate, it should be for when you're just doing a still frame and not for when you're doing your general scanning. Okay, let's go back to our slide I have one last thing to talk about, and that's your scanning cards, and those will be on Blackboard. And we have a scanning card for your anterior knee and for your posterior knee, so that will aid you in your journey through our badging program. I want to thank you for joining us for this episode of UltraSound Bites, and we'll see you on the next one.